Hello all, welcome to the final part of the chapter inflammation. So far we have discussed about acute and chronic inflammation. What are the events, what are the mediators, what are the cells, what are the outcomes. And we have seen that in chronic inflammation, one of the hallmark feature of the in chronic inflammation is that fibrosis or tissue repair and wound healing. Now we are going to see in detail about the process of tissue repair. You should know this process because almost all injuries heal by scar formation or fibrosis. So let us see what is repair. Repair is also called as healing. It refers to restoration of the tissue architecture and function after an injury. We have two terminologies here, repair and healing. The word repair we use when there is any restoration of parenchyma and the connective tissue, and healing we use for surface epithelium. But most of the time both terms are used interchangeably. There are two processes by which the repair of the damaged tissue occurs. Number one, regeneration, which restores the normal cells. This is true in case of epithelial cells, because epithelial cells they can regenerate by its own, and the deposition of connective tissue, that is scarring. So these are the two processes by which repair occurs. Let us see first what is regeneration. Some cells in our body have the capacity to return to a normal state by replacing them with another set of new cells. We call this process as regeneration. How regeneration occurs? Regeneration occurs as a result of proliferation of differentiated cells. The best and classical example of regeneration is liver regeneration. And in our body, I have told you, epithelium, tissue, stem cells, all those have this inborn property that is able to regenerate. As a result of this, they will be able to restore the damaged cells. You can see this picture. Whenever there is a mild or a superficial injury, see here, this is a mild injury. So the cells will undergo regeneration. Whenever the severity is very high, the regeneration won't be able to manage is not that enough to replace the damaged cells. So definitely they have to heal by scar formation. So these are the two main mechanisms by which tissue repair occurs. Fine. So that is regeneration. And in regeneration, what I told, hepatocytes, epithelium of the skin and intestine, tissue, stem cells and their progenitors. Please remember those structures. Then second thing is called connective tissue deposition or scar formation. Suppose if the injury is so severe that even though regeneration happens, it is not adequate to restore the normal function. What happens? The repair will occur by laying down the connective tissue, and which finally result in what we call it as scar formation. Fine. What do you mean by the term fibrosis? As a result of the chronic inflammation in some parenchymal solid organs like liver, lungs, kidney, what happens? There will be deposition of collagen. So this collagen deposition we call it as what? Fibrosis. Am I right? Yes. And at the same time, if this occurs in some tissue space, for example, in a condition called as, you will read it in the chapter lungs, organizing pneumonia. There will be an inflammatory exudate in the alveolar spaces. It is not a part of the solid organ. Am I right? So it actually happens in a tissue space. In such a condition, we use the term organization. See, like how I have used the word repair and healing interchangeably. Here, fibrosis and organization. But organization, most commonly it applies to what? Yes, the fibrosis which develops in the tissue space. We call it as organization, as in case of organizing pneumonia affecting the lungs, and it has been asked. Okay, this has been asked once in an MCQ. Whatever be, whether it is a fibrosis, whether it is an organization, whether it is regeneration, there are some common mechanism. Okay, both has to undergo. First, let us see about the tissue regeneration. How the cells are regenerating? When the cells are damaged, they are stimulated by some growth factors, and these growth factors will what? Stimulate the tissue stem cells, because the stem cells are the progenitors, and these stem cells will form the new cells. Okay, that is the basic principle behind regeneration. First, let us see what are the growth factors, or what are the signals and control mechanisms. Okay, let us see that. So there are some structures which mainly helps in this proliferation or this signaling, or which produce some growth factors. Number one, vascular endothelial cells, because one of the most important sign of healing is angiogenesis. This is very, very important. What is angiogenesis? Formation of new vessels. And this formation of new vessels will accelerate the process of healing. And the second thing is the fibroblast cells. I know these fibroblast cells are going to form the collagen. So collagen deposition, fibrosis and organization. I told you, yes. And whether the cells can undergo regeneration or not, it depends upon the ability of the tissue stem cells. See, not all the cells in our body can undergo regeneration. For example, please consider neurons, cardiac myocytes. Fine. When they undergo injury, I am writing hash for injury. What happens? They fail to regenerate. That is why we say neuronal injury, or in case of myocardial infarction, the patient will be unable to recover very soon. Am I right? There will be a complete permanent loss of function. At the same time, whenever there is an epithelial injury, they will easily regenerate. So we have different types of tissues in our body based on the presence of stem cells. We have divided the various tissues in our body into three groups. Number one is called as labile tissues, or continuously dividing tissues. The best example are the surface epithelium, the stratified squamous epithelium of the skin, oral cavity, cuboidal epithelium of duct, the columnar epithelium of gastrointestinal tract and fallopian tube, the transitional epithelium of urinary tract. Whenever there is a damage to these structures, immediately they will undergo regeneration. Why? Because the stem cells are intact, they will immediately secrete the growth factors for regeneration. These are called as labile cells. Number two is called as stable tissues. That means there are some cells in our body which will be always in the G0 stage. What is the G0 stage in the cell cycle? G0 stage in the cell cycle is what we call it as the quiescent stage. Am I right? Yes. That means they only have a minimal proliferative activity in their normal state. That means normally they won't divide, they will be dormant. But whenever they undergo some injury, what will happen? They will retain the capability to regenerate or divide. So these cells will divide only in response to injury or some loss of tissue mass. What are the cells? Examples of stable cells, very important: liver, kidney, pancreas, as well as endothelial cells, fibroblast and smooth muscle cells. You can't afford to skip any of these points. You should remember all this. Each of this is in MCQ. Which of the following are examples of stable cells? Which of the following are examples of labile tissues? And out of that, in stable cells, liver is a very must known thing, because we are going to discuss in detail about liver regeneration. Then and I have told you, liver, kidney, pancreas and all those things. Out of all these structure, except liver, rest all have a very limited capacity. So if someone asks you which of the following is the best example of a stable tissue, you can mark all answers, of course, no problem. But remember, liver is an exception. Usually I told you stable tissues means they will be in the dormant stage, they won't divide. But exception is liver. Liver has very high ability or potential to regenerate. Then what are permanent tissues? There are some cells in the body. They don't have the ability to divide. Fine. Whenever there is an injury or in the normal state, they won't divide. The best example are, I told you, neurons and the cardiac myocyte. And remember, and one more thing, smooth muscles I have mentioned under stable tissue, whereas the skeletal muscles, it is usually classified under the permanent tissue. But in the skeletal muscles, we have something what we call as the satellite cells. And remember, these satellite cells have some regenerative capacity. This is actually a 10th edition update. Okay, this is a 10th edition update. Please focus on this point. Skeletal muscle, it is a permanent tissue, but the satellite cells, if they are specifically, you can write they have the ability to divide. Okay, fine. Now let us see what are the growth factors. What are the growth factors? I told you, all this regeneration is mainly done, or it is accelerated with the help of some growth factors as well as some extracellular matrix. Let us apply our very basic knowledge. So far, I hope you will get oriented about what happens in regeneration or in tissue repair. Using this knowledge, let us see how the liver undergo regeneration. Liver regeneration, children, it is a short note question for university. Fine. I told you the liver cell, even though they are classified under stable cells, even though they remain dormant during the quiescent phase, they have an exceptionally very high capacity to undergo regeneration. That is one of the major reason by which even after partial hepatectomy, within a very few period of time, what happens? The liver attains the normal or the original size, and that is why we are undergoing doing liver transplantation. Fine. Yes. So the regeneration of the liver occurs by two mechanisms. Number one is the proliferation of remaining hepatocytes. For example, this is the liver. I am cutting this part of liver. Fine. So now what is remaining? Is this. Okay. This dotted portion is removed. So these are the remaining hepatocytes. These remaining hepatocytes, they may undergo proliferation. That is the first step. Okay. Yes. And the second step is liver regeneration from the progenitor cells. So either the remaining cells will undergo replication and they will make up the whole liver, or the stem cells, because liver also have stem cells. Where are the stem cells in the liver present? They are called as the oval cells, where they are present in the canals of herring. Am I right? In the canals of herring, the oval cells are present. Am I right? The stem cells, of the liver we call as oval cells. These oval cells will has a very high proliferative capacity. They will form new hepatocytes. So either the remaining one will replicate, or from the stem cells new hepatocytes are formed. Let us see both of them in detail. Fine. See. So first the proliferation of remaining hepatocytes. Proliferation of remaining hepatocytes. Actually, this is the major mechanism. This is the major mechanism of regeneration, because from the stem cells, that is following what forms some 10%, this forms around some 90%. Okay, this is the classical model which has been well appreciated. Fine. So whenever the tissue undergo injury, there will be some cytokines and growth factors. Cytokines and growth factors. These cytokines and growth factors will stimulate the remaining hepatocytes to further produce some other growth factors which is responsible for, because I told you, hepatocytes, they will be usually in what stage? They will be usually in G0 or the quiescent or the dormant state. These growth factors will facilitate the conversion of the cells which are present in G0 to G1 phase, S phase, and finally they will help in liver regeneration. Fine. Yes. And we have a very some 1 to 2 steps there which is very important. Fine. Let us focus on the picture. Fine. So whenever there is hepatectomy, there occurs 2 steps. Number 1 is what we call it as priming, and number 2 is what we call it as cell proliferation. Okay. Yes. Fine. What do you mean by priming? Priming means I told you, that is, it is the first step. Priming means it is the first step. The step of priming is actually initiated by 2 growth factors. One is what we call it as TNF, very important, TNF, and another one is called as interleukin 6. Priming actually refers to recruitment. Okay, how the neutrophils are recruitment. Here the recruitment of hepatocytes. Okay, the hepatocytes are recruited. Okay, that process is called as priming. And as a result of priming, what will happen? The cells are initially in the G0 phase. They will convert into G1. That is G0 to G1 transition. Now the cells have the capacity to divide. Here comes the role of EGF, that is epidermal growth factor, transforming growth factor alpha. It is not beta. TGF beta, it is an anti-inflammation that comes in wound healing. We will discuss that short. And hepatocyte growth factor, it is also called as, yes, can anyone recollect what is it called as? Scatter factor. Super. And this hepatocyte growth factor, EGF and TGF alpha, they helps in cellular proliferation. So first step is priming and the second step is cellular proliferation. What is the question? What all you should remember here? You should remember what are the growth factors. Okay, what are the growth factors which involves in the steps? TNF and interleukin 6 in priming, EGF, TGF alpha and HGF in case of cellular proliferation or the second stage. Fine. Yes, this is what they have mentioned in this paragraph. Nothing more. Okay, just of course, even though it is asked as a short note question, you should know what are the steps, the priming and cellular proliferation. Okay, these are the 2 steps under the first major mechanism, that is the proliferation of hepatocytes following partial hepatectomy, which follows the 90%. This is a major mechanism. Fine. Yes, please go through these points here. See HGF, TGF alpha, okay, and how they are training. What is that? Priming, transition from G0 to G1 phase and all those things. Fine. Yes. Then liver regeneration from the progenitor cells. We have oval cells. Okay, that is the stem cells which are located in the canals of Henry. Okay, canals of Henry. And what are these canals of Henry? They are the place where the biliary canaliculae connect with that of the larger bile duct. Fine. And these cells, they will undergo stimulation and they will form the new stem cells. That is the mechanism of how the stem cells give rise to new hepatocytes. That is not that much well established. That is why that is the less mechanism. It forms just 10%. There is a major mechanism is proliferation of the remaining hepatocytes following partial hepatectomy. Fine. Yes. So this is how, fine, what liver regeneration occurs. Here comes a question. Suppose my liver undergoes injury, but still the residual tissue, that is the remaining hepatocytes, it is intact. Then only these above steps will happen. At the same time, my injury is very severe. Suppose I am getting a stab injury into my liver. Fine, a blunt penetrating trauma. What will happen? The remaining hepatocytes, they may undergo inflammation. They may have necrosis. So they can't regenerate. They will lose the ability to regenerate. They will heal by scar formation because of extensive collagen reticular deposition, fibrosis. Finally, liver abscess may happen. So this point is very, very important. The restoration, I'm highlighting with another color, the restoration of normal tissue can occur only if the residual tissue is structurally intact. Fine? Yes. With this, let us go and study how the repair occurs by connective tissue deposition. Connective tissue deposition, we have studied the first mechanism. How the tissue repair occurs by two mechanisms. Number one, by regeneration, that we have discussed. We have discussed about regeneration of liver. Let us see the second mechanism, that is repair by connective tissue deposition. Repair by connective tissue deposition. Okay. Now let us see what are the steps in scar formation. What is scar? Scar means, remember, the normal tissue parenchyma is replaced by collagen. The normal, wherever the normal, the tissue parenchyma is replaced by collagen, we use the term scar. What are the steps in scar formation? Am I right? Following tissue injury, there will be a lot of steps. Okay, the end product, or the final outcome of all these steps is nothing else but connective tissue deposition and scar formation. Suppose I have a clean cut incised injury on my hand. What will happen? What will happen first? Within minutes, what will happen? A hemostatic plug composed of platelets. We have primary and secondary hemostatic plug. I am not going to that in detail because that we will discuss in the chapter hemodynamics. Then finally, there will be deposition of fibrin. So first there will be platelets, hemostatic plug, primary is by the platelets, secondary is by the coagulation factors, and finally fibrin deposition. As a result of that, what will happen? Inflammation. So chemokines, all this will come. Fine, from the activated platelets, they will help in chemotaxis, recruitment of neutrophils. Neutrophils will be replaced by the macrophages over another some 48 hours. Fine, finally what will happen? All the debris, everything will be cleared. Then what will happen? Yes, regeneration, am I right? Yes, which will take some another 10 days. The epithelial cells, fibroblast, all these proliferate because they have to close the clean wound. Fine, epithelial cells mainly produce some growth factors, and endothelial cells and pericytes. I told you, endothelial cells and pericytes, they are the main important cells which form new blood vessels. What is the process in which the new blood vessels are formed? Called as angiogenesis. Angiogenesis is the most important, most important process, because this only, whenever there is an increased blood supply, then only healing will happen. Am I right? When healing will happen, that you will have seen in diabetic patient, due to the poor blood supply, what will happen? It will take a very long time for a very small wound to heal. Fine. Yes, we will see what are the conditions which facilitate the healing, what are the conditions which inhibit healing, you will see. And fibroblast, which lays down the collagen fibers. So in all these condition occurs, finally there will be deposition of the fibroblast, deposition of the loose connective tissue, and that is what we call it as granulation tissue. You should not confuse granulation tissue. Granulation tissue should not be confused with the granuloma or granulomatous inflammation. Granulomatous inflammation is a morphological type of chronic inflammation, whereas granulation tissue refers to, that is what? The new blood vessels along with the collagen and loose areolar connective tissue, deposition during the process of wound healing, we call it as granulation tissue. See, you can see here, first there will be platelets, and these platelets are finally replaced by some fibrin. After that, at the list of inflammation, finally what we have, fibroblast and connective tissue deposition. That is how it is heals by scar formation. See, you can see granulation tissue. Yes. Now I am going to I told you, in granuloma, what are there? In granuloma, there will be Langerhans giant cell, which will be covered by a collar of lymphocytes and fibroblast. All those together only we call it as the granuloma. Structure of granuloma is important. Similarly, what is granulation tissue? Granulation tissue, I am writing here separately. Granulation tissue, this is a very important basic question. Granulation tissue is nothing else but fibroblast, loose connective tissue, new blood vessels, and finally mononuclear cells, like neutrophils, leukocytes, all those things. Fine? Yes. What does the word terminology granulation mean? The term granulation means the pink, soft, granular, gross appearance. Okay, when you observe, okay, if you go to surgery posting, if you see any healing ulcer, I have told you what is ulcer. Ulcer is a breach in the, okay, loss of integrity of the normal epithelium or the mucosa of the body. Am I right? That is ulcer. When the ulcer is healing, you can see a very pink, okay, soft, okay, a reddish granular appearance, and that indicates, don't think that it is bleeding. No, that is actually the granulation tissue. Granulation tissue is a very good indicator. It is an excellent indicator or a very good indicator of wound healing. I hope it is very clear for you. Yes. And histologically, as I have told you, so grossly it will appear like a pink soft granular. Similarly, I told you in granulomatous inflammation, there will be caseating granuloma. Am I right? You will get a cheesy appearance on gross because of the mycoalic acid cell present in the Mycobacterium tuberculosis and all. Whereas non-caseating granuloma you will see in case of leprosy and sarcoidosis. And similarly, here in granulation tissue, when you see histopathology, you will see fibroblast, then delicate capillaries, loose ECM, and you can also see macrophages. Fine. Yes, what you see, how you define granulation tissue, all those features you can appreciate in histopathology too. Fine. Yes. And once granulation tissue occurs, so what happens? See, what are the steps? First epithelial cells, then angiogenesis, fibroblast, formation of granulation tissue, and finally this granulation tissue will be finally replaced completely by collagen. That is what we call as a fibrous scar. And I have already told you in the last class itself, we have two pathways of activation, classical pathway and what? The alternative pathway. Now you are going to tell which type of pathway is involved in tissue fibrosis, tissue repair. Yes, very good. It is the alternative pathway or the M2. M2 macrophages means alternatively activated macrophages. They will secrete some growth factors. I told you, TGF beta, interleukin 10. Remember? Yes, all those will stimulate fibroblast proliferation. They will stimulate connective tissue synthesis and deposition. And this is responsible for what? Termination of inflammation and hence what? Tissue repair. Now let us see each step. So already the rest of the steps, the epithelial cells, okay, all those we have studied. What is the next step? Once the epithelial cells comes into action, the endothelial cells, yes, the vascular endothelial cells, they have to form the new blood vessel. What is this process called as? Angiogenesis. Let us see what is angiogenesis. Angiogenesis means the process of new blood vessels which develops from the existing blood vessels. Okay, from the existing vessels, there will be formation of new blood vessels. Okay, that is, for example, this is a tissue, okay, it's a piece of tissue, and already there is a blood vessel. As a result of injury, from this blood vessel I am getting new branches like a collaterals. Fine. Why? Because to increase the blood supply to the tissue. That is the reason. Fine. Yes. Okay. What are the various steps in which the angiogenesis occurs? Please focus on this. Number 1, vasodilation. In response to increased vascular permeability and the nitric oxide which is released, there will be formation of vascular endothelial factor, growth factor, VEGF. VEGF is a very important growth factor, like how we have studied in TNF and all. In case of liver regeneration, VEGF is very important in angiogenesis. So once VEGF comes, the pericytes, you know what are pericytes? Yes, these are the cells which lines the capillaries. From basic anatomy, we have different types of pericytes, and the pericytes will separate. Why? Because see, these are the capillaries. I am writing, these are the, okay, this is the blood vessel wall. Okay, these are the capillaries, and what I am drawing is the pericytes. Okay, this is the blood vessel, and this is the lumen of the blood vessel. This is the lumen of the blood vessel. So, if a new vessel has to come, what happens? These pericytes, okay, I am drawing it again. These pericytes, they will separate. Okay, that is, you will see some spaces between the pericytes. And through here, new vessels will sprout like this. Sprouting of new blood vessels. Fine? Yes. So, separation of pericytes. Then, migration of endothelial cells. Endothelial cells proliferation. The proliferated endothelial cells will form new capillary tubes. Fine? Yes. And finally, the pericytes and all, they will come back to the original position, and finally, what will happen? The endothelial proliferation will be suppressed. First, we have lot of growth factors. involved in angiogenesis. Out of that, the most one is VEGF. In VEGF, we have VEGF-A that is going to stimulate mainly the migration and proliferation of endothelial cells, and that is mainly going to initiate the process of capillary sprouting. So VEGF. How the VEGF occurs? Yes, it will, as a result of the increased vascular permeability, it further, the VEGF further increases the vascular permeability. Fine? Yes. And I told you there is some process what we call it as proliferation of endothelial cells, because the endothelial cell proliferation is very important for capillary tube formation. That is mainly by fibroblast growth factor, mainly FGF2. Each of these is an MCQ question. Each of these is an MCQ question. Endothelial cell proliferation is by fibroblast. Fine. Proliferation and migration of endothelial cells are what the major initiating factor for capillary sprouting is VEGF. So each of this is a very, very important thing. And the fibroblast growth factor, as the name indicates, yes, it is going to cause migration of macrophages and fibroblasts. Am I right? Yes. We have angiopoietins like erythropoietin. We have angiopoietins 1 and 2. They are growth factors, and they also what? Play a very, very important role in angiogenesis. Okay, they also play an important role in angiogenesis. See, let us see this picture. Let us see this picture. You can see the basement membrane, you can see the endothelium, and you can see the pericytes. Okay, these pericytes, what? They will undergo separation, and the VEGF and all will help in what? New capillary blood vessels sprouting. Fine. Yes. And how the pericyte undergo detachment? Mainly, of course, angiopoietin helps in pericyte detachment. This is another potential MCQ question. Fine. Yes. And the basement membrane is there. That also has to be undergo degeneration. That is with the help of enzymes called as MMP, matrix metalloproteinases. They are proteinases. Okay, they are what proteases. They are a group of proteases. They are going to break the basement membrane. Don't worry, we will discuss that a bit little in short. Okay, very soon we will discuss. Fine. Finally, the sprouting, all those happens. Then the pericytes will be further recruited back, and finally a new vessel will be formed. See, this is how the process of angiogenesis occurs. VEGF, then fibroblast growth factor, angiopoietin 1 and 2. Angiopoietin mainly helps in detachment of the pericytes. Okay, this is an MCQ. I am highlighting that again. Then here what else I have discussed. See, this is a granulation tissue. You can see here granulation tissue. Fine. You can see blood vessels, edema. See, you can see, what are they? These are the blood vessels. Right, and you can see the blue structures, which are the inflammatory cells. Okay, all those things you can see. And you can see collagen fibers. Fine. Yes, collagen fibers are very few appreciated, very because this is normal staining. Whereas what is this stain? Yes, you have already mastered the stains. What is this stain? Yes, this is very good. Masson's trichrome stain. This is the stain of choice for demonstrating collagen. See, the whole, everything, most of the tissue is bluish in color. That is, the complete tissue has been replaced by collagen deposition. And what you are seeing here, this is nothing else but the the fibrin and the blood vessels, okay, and rest of the structures. Fine. So this is the trichrome stain. So whenever immediately when you see this, you should identify that it is a granulation tissue. This question has been repeatedly asked in all the exams. They will give a picture like this. They will identify what is it? Granulation tissue. What is it? Granulation tissue. Okay, granulation tissue. I hope that is very clear for you. Yes. And in granulation tissue, okay, fine. Yes. That I have to because initially there will be one type of collagen that will be replaced by another type. Okay, that we will discuss very soon in types of wound healing. Fine. So that is angiogenesis. Fine. Yes. And once angiogenesis is done, we have to what? Deposition of connective tissue. Am I right? That is the next step. No, angiogenesis is done. What is that? Next step is formation of granulation tissue, all those, and connective tissue deposition. The connective tissue deposition is mainly by our proliferation of fibroblast. What are the growth factors here? PDGF, FGF2, and TGF-beta. Platelet derived growth factor, fibroblast growth factor. You can very easily remember. So here there is a proliferation of fibroblast, that is mainly with the help of fibroblast growth factor. And remember, the most potent factor is TGF-beta. It is the most important cytokine for the synthesis and deposition of connective tissue proteins. Can you say which type of pathway result in tissue repair like this? Yes, very good. It is the alternatively activated or the M2 macrophages. Okay, that is mainly responsible for synthesizing these growth factors, and that is mainly helping for deposition of connective tissue, fibroblast proliferation. Fine. I hope things are very clear for you. Yes. Fine. Okay. So this TGF beta is going to stimulate the fibroblast migration, proliferation, increase the synthesis of collagen and fibronectin. It decreases the degradation of extracellular matrix. This is a very, very important. TGF beta will inhibit MMP. What are MMP, children? MMP is matrix metalloproteinase. They are going to degrade the basement membrane. The degradation of basement membrane is required only during angiogenesis, because only if the basement membrane is degraded, the new vessels can sprout out. But during connective tissue, this process has to be inhibited. Imagine a condition. Okay, imagine a condition. See, this is like, for example, this is a water tank. Okay, I am pouring water. You can consider this water as collagen. And the base of the tank you can consider as a BM, basement membrane. Suppose there is a hole. Okay, suppose there is a hole. 1 second. Suppose there is a hole. Fine. And through this the water is leaking, or the collagen is leaking. Why? Okay, collagen is leaking. Then what is the what meaning of adding more and more water into this? Because it is leaking, right? So that is the same process which happens here. So if the tissue deposition, if the collagen all has to undergo deposited, what happens? What should be there? The basement membrane should be intact, because during the process of this scar formation, we have a very enzyme. We have a very a crucial enzyme. See, this matrix metalloproteinases is a double-edged sword. Okay, it is a double-edged sword, because during angiogenesis, what this enzyme should be activated. Then only the basement membrane can undergo degradation. Then only the capillary tubes can undergo sprouting. Fine? Yes. But during the deposition of connective tissue, this enzyme has to be inhibited. Then only the collagen can be deposited. This inhibition of matrix metalloproteinases is one of the most important key function of the TGF beta, transforming growth factor beta. Then only the more and more collagen can be added. Okay, am I right? I hope this point is very clear for you. Yes. And remember, this TGF beta is not only involved in scar formation, but it is also in case of chronic inflammation. We have seen conditions like fibrosis of the lung, liver and kidney in response to chronic inflammation. There also the fibrosis is because of TGF beta. And remember, TGF beta is going to inhibit lymphocyte proliferation. Hence, it is an anti-inflammatory cytokine which terminates the inflammatory response. I have told you, in acute inflammation, we have only one anti-inflammatory, that is lipoxin. Similar in chronic inflammation, the termination of the inflammation is brought out by a very, very important cytokine. We call it as TGF beta. Then, as the healing process progresses, what will happen? The fibroblast will be increasing, the new vessels will be decreasing. So, there will be increased deposition of the extracellular matrix. And I told you, the collagen deposition, it is a critical for the development of strength in the healing wound site. That means whenever there is more collagen deposition, the wound will be more strengthened. Fine? Yes. And once we get an injury, of course it will take some time. Finally, it will close by scar formation. If you see, after some period of time, this scar will undergo contraction. Am I right? You can see the scar contraction. This contraction of the scar is because of some group of cells called as myofibroblast. What are myofibroblast? They are a modified fibroblast. They have some actin filaments present within them. Okay, they have some features of smooth muscle cells, because muscle cells only have the ability for contraction. And these specialized fibroblasts we call it as myofibroblast, and these myofibroblasts are very these myofibroblasts are responsible for what? These myofibroblasts are responsible for what we call it as the scar contraction. Okay, I hope that point is very clear for you. Okay, this scar contraction. Fine. Yes. So I am drawing it within a separate box here. Fine. Yes. What is it? Myofibroblast. Actin filament, specialized fibroblast. Fine. Then there should be a balance between the synthesis and degradation of extracellular matrix. Am I right? For example, look this picture. This is a what? Tank. Yes, tank of water. So water is coming from the reservoir, and from here the water goes to the field, okay, the paddy fields or whatever it may be. There should be always a balance between the water which flows in and the water which flows out. Flows in and flows out. Suppose if there is no balance, what will happen? Either it will overflow, or what will happen? There will be less water if there is more outflow. So there should, similarly, when the collagen is depositing, when the extracellular matrix is depositing, there should be always a balance between deposition and degradation of the connective tissue. That is mainly with the help of an enzyme called as matrix metalloproteinases. Why they are called as matrix metalloproteinases? They are mainly dependent on zinc. We have MMP 1, 2, 3, all those things. Fine. No need to remember their varieties. They are produced mainly by fibroblast and they are mainly regulated by various cytokines. I told you, during angiogenesis, the MMPs are activated so that the degradation of basement membrane occurs and the capillary sprouting happens. Whereas at the same time, during the tissue deposition, they are mainly inhibited. And those group of inhibitors are called as TIM, that is tissue inhibitors of matrix metalloproteinases. One of the most important tissue inhibitor of matrix proteinases is TGF-beta. Fine. So that is the regulation. Okay, that is the regulation. What are the factors which influence tissue repair? Infection will delay wound healing. Diabetes will delay wound healing. Vitamin C deficiency, delay wound healing because it will inhibit collagen synthesis. Steroids are immunosuppressive. Am I right? Yes. They are going to inhibit TGF-beta. So TGF-beta is inhibited. What will happen? There will be diminished fibrosis. Fine. Yes. Then mechanical factors. Whenever there is an increase, suppose you are suturing. Suppose you are making a suture over the abdominal wall. Abdominal wall is highly tensed wall. Am I right? Because we have a lot of, and suppose we cough, we strain. Okay. What will happen? There will be delayed wound healing due to poor perfusion, that is in diabetes or in peripheral vascular disease. Whenever the blood supply is inadequate, whenever there is any foreign bodies, okay, so or the location of injury, the type of injury. Suppose a very small injury, it will heal very faster. A very penetrating crushed injury, it takes a long time because all the cells are undergoing degeneration. And we have something what we call it as the location of the injury. Am I right? For example, when the wound is located in the myocardium, it will take very long time for heal. At the same time, if it is located on the dorsum of your hand, it will heal very rapidly. So the location of injury. So these are all the factors. These are for completion sake. They may ask in university exams. Next, we are going to see the healing of skin wounds. Healing of skin wounds, they are mainly of two types. Number one is called as healing by first intention and healing by second intention. See, remember, there are a lot of confusion regarding this. This we are telling healing by first intention or healing by second intention is mainly based on the nature and the size of the wound. For example, if the wound is a clean, incised, well-cleaned wound, for example, like this. This is a well-cleaned wound, clean, incised wound. You can well appreciate the margins. Fine. In such case, the healing occurs by first or primary intention. Second intention means suppose you will get a large wound like this, a crushed injury, ill-defined margin, irregular surface, dirty look. Then they will heal by second intention. This is the basic difference. First, you should understand. Let us see healing by first intention. The injury, suppose if it is only, I told clean incised wound, or yes, if you tell a little bit more specific, suppose if the injury is involving only the epithelial layer, how it will heal? I told you by epithelial regeneration, because only epithelium is renewed. There is no need for any fibrosis, scar formation and complex mechanisms here. They will mainly repair by epithelial generation. This is called as primary intention, or what we call as primary union. One of the best example is clean, uninfected surgical incision. Fine? Yes. So what is happening here? There will be some alteration in the epithelial basement membrane and all. Finally, the epithelial basement membrane, the new epithelial cells will undergo regeneration and they will heal. Okay? Yes. Fine. So what are the three processes? Again, inflammation will be there first, then epithelial cells, and finally there will be a small scar. The scar formation will be very light, very minimal. Fine? Yes. See, let us see the healing by primary intention. See, you can see in this picture, we have to know the healing by primary intention. What are the steps? See, healing by primary intention. See, within 24 hours, there will be neutrophils, which will be further replaced by macrophages in 3 to 7 days. And finally, there will be complete scar formation and after granulation tissues and all. Fine? Yes. And remember, there are some basic differences by healing by first intention and second intention we are going to see. So, again, the same pathway. I got an injury. There will be rapid activation of coagulation pathway, formation of blood clot. This clot, the activated platelets will release some growth factors, okay, and cytokines, which will what? Which will recruit neutrophils. So, within 24 hours, the neutrophils will be seen, okay, and they will migrate towards the fibrin clot. These steps, number 1, number 2. You should write this in a flow chart, in the form of a flow chart. Fine? Yes. And finally, what will happen? Yes. Once you see the edge of the wound, for example, I am drawing a picture here. This is a wound, and here you have fibrin clot, and here comes neutrophils, okay, neutrophils. The neutrophils will be more accumulated, they will be more accumulated towards the edge of the incision. Fine? Yes. And within another 24 to 48 hours, they undergo further what? Proliferation. Am I right? Yes. And by day 3, these neutrophils will be replaced by macrophages and granulation tissue. You know what you mean by granulation tissue? Yes, new blood vessels, then along with the mononuclear leukocytes, am I right? Along with this fibrin deposition, all those. So all this is what we call it as our granulation tissue. Okay, once again I am going to that picture. What is granulation tissue? See, that is fibroblast, loose areolar connective tissue, new vessels and mononuclear cells. This is the composition of the granulation tissue. So again, granulation tissue comes into action, but the granulation tissue is very minimal. Here remember, the granulation tissue is very minimal. Granulation tissue is very minimal in case of healing by primary intention. Okay, and finally day 5, the neovascularization or the angiogenesis will be in peak. Of course, from day 3, the new blood vessel will start formation. By the peak or the highest level of neovascularization will be on day 5. This is an MCQ question. Day 5 is important. Fine. And what will happen? More blood vessels, so more leakage of plasma proteins, increased vascular permeability. So it is often edematous, then formation of fibroblast, deposition of extracellular matrix, and by second weeks, that is almost by the end of by the 14 days, what will happen? All this, that is, there will be only fibroblast proliferation, the new vascularization, everything will be suppressed, and by the end of first month, the scar will comprises what? Of a purely of connective tissue, and I told you, more the collagen deposition, more will be the strength of the wound. This is the healing by primary intention. See, within 24 hours we have the neutrophils, 3 to 7 days macrophages, and at the same time, okay, in the 3 to 7 days, by the third day only the granulation tissue start. Granulation starts on day 5, peak of neovascularization. Then weeks, okay, by the weeks you will have collagen deposition, and month we have scar. Whereas we have some changes in second intention, and remember here granulation tissue is minimal granulation tissue. Once this is done, what is healing by second intention? The same thing as like of first intention, okay, but I'm going to explain you what are the differences. Number 1, in which injuries you will have second intention healing. Number 1, when large tissue deficit, more exudate, more necrosis, more intense inflammation. Am I right? Yes. So here the mere epithelial regeneration cannot work because a large tissue, abnormal tissues, they has to be replaced. Fine? Yes. In order to replace larger volume of necrotic debris and exudate, what will happen? Large amount of granulation tissue will be formed. We have to fill the bigger gap. Am I right? So large granulation tissue will cause more scar formation. Fine? Yes. So remember, this is the point I have to stress in, and here only you are going to get a very, very important MCQ question. Please open your eyes here. Initially, The granulation tissue, I told you, the granulation tissue which is forming by some 3rd to 7th days, they mainly have type 3 collagen. Granulation tissue, I am writing it here again, granulation tissue, type 3 collagen. See, I will show the picture here. You can see the injury is so broad, more neutrophil regulation. You can see a very large granulation tissue, and the scar formation is very large. And since the scar formation is very big size, here comes the role of the myofibroblast, which finally result in scar contraction. Here comes a question: in primary intention, there is no scar contraction. Don't please write there is no scar formation in primary intention. In primary intention, the scar formation is there, which is minimal, and there is no scar contraction. Whereas in case of secondary, scar contraction is present. Very, very important point. Star it. Fine? Yes. So type 3 collagen will be there in granulation tissue. This will be further replaced by type 1 collagen. So straight away direct question, what type of collagen is present in granulation tissue? We are going to answer it is type 3 collagen. So in secondary intention, a very, very important feature of secondary intention which differentiate it from the primary intention is wound contraction with the help of myofibroblast, which are modified fibroblasts having smooth muscle cell properties, have actin filaments. Okay, yes. And remember, within 6 weeks, the large skin defects may be reduced to 5 to 10% each of their original size by contraction. Even though there is a large scar formation, you can see, in patients who have burn injuries over the neck and all, you can see finally they will not be able to move the neck freely like a normal person. Why? Because initially there won't be any problem, but after some few months, what will happen? This scar which has been formed as a result of the burn injury will undergo contraction. This contraction means what? Yeah, that is a pulling up. Am I right? Yes, the fibroblast will contract, this myofibroblast, and as a result there will be restricted mobility of the head and neck. Fine? Yes. Now let us see what about the wound strength. Fine? Yes. If we suture the wound properly, they will attain around 70% strength of the normal skin. Here comes the question. The 70%, of the strength, it occurs by around 2 months. 70 to 80% occurs by some 3 months. And remember, very important point I am writing, won't never acquire 100% strength. This is a very, very important question. Okay, this is a very, very important question. I am drawing it in a box. Wound never occurs 100% strength of normal tissue. Once you get an injury, that's an injury. The strength of that tissue won't be, it will be never 100% equal to that of your normal tissue. Maximum 80%. That's all. Fine? Yes. And I told you that we have two terminology. One is called as fibrosis, another one is organization. Basically, both remains the same. Organization, when the fibrosis takes place in some space, like organizing pneumonia. And fibrosis, whenever there is collagen deposition, I told liver undergo fibrosis whenever the injury is very high. Am I right? Very large injury. Yes, similarly, fibrosis occurs in case of liver cirrhosis, systemic sclerosis or scleroderma, fibrosing disease of the lung like idiopathic pulmonary fibrosis, pneumoconiosis, drug and radiation induced pulmonary fibrosis, end-stage kidney disease and constrictive pericarditis. Don't worry, don't panic. Just if you can remember, please remember this name. These are examples of some fibrotic disorders. We will discuss in detail in the corresponding chapters. Okay. Yes, I told you there should be a balance in deposition and degradation of collagen. Suppose if the collagen is not deposited adequately, there will be defect in healing. Suppose if it is more, it will have what result in contraction. That is scars, that is contractures we will discuss. Whenever there is a defect in healing, like venous leg ulcers, when the wound doesn't heal, in case of patients who have chronic venous hypertension, congestive cardiac failure, varicose vein, what will happen? There will be deposition of iron pigment hemosiderin, and finally these ulcers will be It takes very long time. If you see to go to surgery OPD, a diabetic patient will have initially a small ulcer which will completely erode his whole foot, which has to be amputated. Fine. Yes. So due to pure delivery of oxygen. Then in arterial ulcers develops in patients who are in diabetes, atherosclerosis. Fine. What will happen? The blood won't reach. In venous leg ulcer, the blood is already there, but it is not able to oxygenate it. Venous. Okay. If you see in the lower foot and all, what will happen? The venous blood has to pump back to the heart, for oxygenation, but there won't be any oxygenation of blood. So the old blood will remain stagnant for a long time. Hemosiderin deposition. You will get a brownish discoloration of the skin and all. Then in arterial ulcers, ischemia is the problem. Because of atherosclerosis, narrowing of the lumen of the blood vessels or thickening of the walls of the blood vessels, the blood will very poorly reaches the healing site, and it will take very long time. Of course, in diabetic ulcers, and pressure source due to compression of the tissues against the bone. So all this you can read all these type of ulcers in your surgery. Okay, fine. Okay. And what is wound dehiscence? Fine. What do you mean by wound dehiscence? Suppose this incision, that is the incised wound, if it reopens internally or externally, we call it as wound dehiscence. For example, this is a wound. I am doing suture like this. Due to some reason, these sutures undergo breakage. Again, the wound opens like this. This is called as wound dehiscence. What are the factors? Vascular insufficiency, malnutrition, infections, all those things. Or in case of abdomen, suppose you see, if you go to surgery OPD, the patients who are having any suture over the abdomen, what will happen? Whenever the patient whenever the patient go for toilet strain during defecation, during micturition, what will happen? There will be dehiscence. Yes. So that is defect. Next, let us see the last topic. That is nothing else but excessive scarring. So, whenever there is a defect, wound dehiscence, all those happen. It will take a very long time, ulcers, everything. Whenever there is excessive formation of this repair process, it can lead to two conditions called as hypertrophic scars and keloids. That is, first of all, let us see what is hypertrophic scar and what is keloid. Okay, these are the two important terminologies you have to I am drawing a picture. So, fine. 1 second. Okay, I hope which region I am drawing. Fine, this is an upper arm. I am getting an injury here. Of course, scar formation happens. Suppose there is excess collagen deposition like this. Confined within the boundaries. The word is very important. Excess collagen confined within margins. We call it as hypertrophic scar. The same thing. The same excess collagen deposition. It is crossing the boundaries. It is reaching the axilla, covering the upper arm, okay, the humeral, okay, all those structures, midline. This is what we call it as keloid. So, excessive collagen deposition within the confined margins. We call it as hypertrophic scar. If it crosses the margin, see, this is an example of hypertrophic scar. See, this is an example of within the margin. See, whereas keloid, the injury is only here. See, where it progresses. See, this is keloid. Okay? Yes. So, if the scar tissue grows beyond the boundaries and it do not regress, keloid. Whereas hypertrophic scar, they will regress over months. That you itself had, okay, at least most of us would have get some kind of injury. Okay, recently I got an injury I fell from bike. So I got a small injury over my dorsum of the foot. So after some 6 months, my skin is normal. I am not able to even appreciate or even see where the scar has formed. It will completely regress. Hypertrophic scar is also like that. It will completely regress over a few months. Whereas keloids, it will persist. It won't disintegrate, as you can see in this picture. Fine? Yes. And hypertrophic scars, they more generally developed after some thermal injuries, which involves the deep layer of the dermis. And keloid, in keloid formation, there are some predisposing factors. It is more common in African Americans. The reasons of the same is not known. Fine. And why there is a need for the scar formation, everything, what are the structures which helps in scar formation. And finally, you have something what we call it as abundant myofibroblast. See, this is one of the reason of formation of hypertrophic scar. Whenever there is an abundant myofibroblast, because of the scar contraction, the incidence of hypertrophic scar is very high. Okay, or the chances of forming hypertrophic scar is very high. So you can see in this picture, okay, hypertrophic scar and keloid. This is a microscopic appearance of keloid. You can appreciate, this is the, this is skin first of all. This is the epidermis of the skin. Whenever you see a histopathology picture, first don't immediately go and appreciate the findings. Don't mug up the pictures. First, okay, what structure? This is skin. How it is skin? You can see the stratum, okay, various strata. This is the epidermis. This is the dermis. And what you can see some mesh, okay, some group of depositions, am I right? Some eosinophilic deposition. These are connective tissue deposition. So probably it will be a keloid. This is a very classical picture, direct picture from the Robbins they are giving in MCQ exams. Okay, you have to identify what it is. It is keloid. So we have discussed the various abnormalities of scar formation, that is hypertrophic scar and keloid. I know this lecture has been a quite long lecture, because you should know, you can't skip any point. Each of the point is very important. Each of this is a potential MCQ question. Fine. So we have discussed the two processes in which the damaged tissues undergo repair: regeneration and connective tissue deposition. In regeneration, we have three types of cells. What are they? Proliferative cells, stable cells, and permanent tissues. Then we have discussed in detail about liver regeneration. Remember, in priming we have TNF and interleukin 6, and then hepatocyte growth factor and comes in cellular proliferation stage. Then fine. Then what are the connective tissue deposition? Inflammation, epithelial cells, endothelial cells, angiogenesis, formation of granulation tissue. Granulation tissue has fibroblast, loose connective tissue, new vessels, and mononuclear cells. What is the type of collagen? Type 3 collagen. Granulation tissue is a good indicator of healing. Fine. Then we have macrophages. What is the pathway? Macrophage activation. It is an alternate pathway. TGF beta, you should remember. And what are the steps of angiogenesis? Angiogenesis can be asked. See, angiogenesis can be asked alone. Angiogenesis can be asked as an essay, or wound healing can be asked as an essay question. Okay, they will give a case history. A male comes to surgery OPD with a incist wound, how the process of wound healing will happen. Then VEGF, FGF2, angiopoietin. Angiopoietin is mainly important. This is an MCQ once asked in AIMS. Which of the following cytokines is involved in detachment of pericyte? Answer is angiopoietin. Direct line from Robbins. Then TGF beta is the most important factor in anti-inflammatory. Then you should know what is myofibroblast. Then what is the balance? Okay, that is TGF beta is going to inhibit the matrix metalloproteinase. They are zinc dependent. Okay, matrix metalloproteinases are zinc cofactor enzymes. This is another MCQ. Fine. Once that is done, what are the factors and what is healing by primary and secondary detection? Please focus on this picture. Focus on this picture. You can understand and write. Okay. On 24 hours and 3 to 7 days within weeks and months. And finally, what is that secondary detection? What is, myofibroblast scar contraction. Scar contraction occurs mainly during secondary intention. Very good. And wound strength never attains 100%. Then what are diabetic ulcers and hypertrophic scar? Hypertrophic scar confined within the margins. It will regress. Keloid won't regress. It will cross the margins of the wound. Fine. Yes. So I think with that we have completed the chapter successfully. Chapter 3, inflammation. Thank you.